recording, and we are going to let folks in. And it looks like we're getting folks to go ahead and to successfully come on in. So far, so good. All right. Well, good morning from near and far. An official good morning to everyone. I'm Seth Stander. If we haven't had a chance to meet live or via recording, I am the Community Aging Specialist for HHCI CARES, which is part of the Hope and Healing Center and Institute. HHCI CARES, the CARES part of that acronym, stands for Caregiving, Aging, Resilience, Ethics, and Spirituality. And CARES is directed by Dr. Peggy Dettermeyer, who I have the pleasure of working with each day. So we have reached the fourth and final Aging with Grace session for this season, where we will focus, as I hope you all can see, on paying for aging, which we're going to cover in some detail during this roughly hour or so. Now, each session, each of the four sessions that we've had this season have been and are being recorded. The recordings and the slides are going to be available to everyone, whether you registered for one or for all of our programs or someplace in between. We want to make sure you've got access to materials. Also, the recordings are going to be embedded on our website, hhci.org, in addition to you receiving links to the recordings and, of course, copies of the slides. Now, HHCI CARES' mission is to serve our ever-growing aging population and the growing population of those who are caring for them, either directly as caregivers or arranging for caregiving experiences. Now, in addition to community education, such as what we're doing today, Peggy and I offer consulting with special emphases on the hopes and challenges of aging, bioethics, the hopes and challenges of caregiving, and navigating the journey of grief, and of course, much more in terms of individual consultation and coaching. Now, the Hope and Healing Center and Institute is a nonprofit. We are physically located on the campus of St. Martin's Episcopal Church here in Houston. And as a separate 501c3, a separate nonprofit organization, we are dedicated to meeting the psychosocial and emotional needs of the entire community. Thanks to some very generous donors and underwriting and a robust philanthropy department, we are grateful to offer our programming to you free of charge. So we're going to rely heavily today on our slides, which again, you're going to receive copies of after this presentation is over. And with that, let's go to the necessary disclaimer, which is that this is an overview of available options when it comes to paying for aging. Ultimately, for details about how these options apply to your specific circumstances, it's best to speak with a financial planning professional. And I'm going to add in here, in addition to speaking with a financial planning professional of your choice, don't forget, and they're going to be listed as they have been in previous resource slides in presentations throughout the Aging with Grace series. Your county, whether it's here in Houston, which would be Harris County, or the surrounding counties around us, or whatever county or territory you find yourself in the United States or beyond, you're going to have something that is an area agency on aging. You're going to have something that serves as an aging and disability resource center, and you're going to have something that serves as a long-term care ombudsman program. So keep that in mind. And again, those links for the ones that are in our area are going to be at the end of various slide presentations. But in your own areas, this is another way to go ahead and look in particular at what financial options are going to be best available to you. How do you max out what you have? And we understand that everybody may be starting in a different place when you contemplate aging in place, when you contemplate aging in a long-term care facility. So we're going to cover what in general the costs are that are associated with aging. I think that may probably be the most straightforward portion of this, because whether you are already living that experience or have loved ones who are, you're well aware of some of those costs already, but we want to make sure that we're not overlooking anything unexpected. We're then going to go ahead and take a quick tour of both Medicare and Medicaid. We're going to discuss what possible private financial options may be available to you as you contemplate the aging in place or aging in facility experience. And then, as I mentioned, various resources, including such agencies as I mentioned a moment ago. So let's just talk in general terms about the costs of aging. Most people, by the time you reach the age of, shall we say, older adulthood, will be in a position after you age into Medicare to be paying Medicare premiums, deductibles, and copays for Medicare. And most importantly, because what is life without prescription medication? For many of us, some of us may be blessed to not need regular medication, but I would say a significant portion of us absolutely need regularly prescribed medication, for which there are typically copays. So Health Use Services, which is just one of many different programs out there that gives you diagnostic information, will go ahead and say in general that a 65-year-old couple is going to end up paying about $400,000 over a 20-year period for their health. Now, is that completely out of pocket? Of course not. That is the value of the medical care that you are receiving primarily as a benefit through such programs as Medicare and or other private insurance. Now, I do need to point out that this assumes an aging in place experience. If you find yourself in a long-term care facility, obviously this number is going to change somewhat radically, and we'll talk about that in just a moment. Monthly care costs. Average is a loaded word, because ultimately, depending on what the cost of living is in your part of the country or world, depending on what you are able to, again, depending on state, depending on nation, whatever can be covered through, say, central government benefits as opposed to private out-of-pocket costs is going to skew this in one direction or another. We're talking about numbers, therefore, that are what you can expect more or less right now here in the state of Texas in the United States. We recognize we have some folks who are international, but we're going to focus on Texas as our case study. So when we talk about homemaker or home health aides, you might recall when we talked in one of our earlier sessions, and if you haven't had a chance to participate in that session, again, you're going to get the recording for the Living Options section of our Aging with Grace series. We talked about the difference between home aides and home health aides. The primary difference between the two, I will say, beyond level of care provided, is whether one is prescribed. Home health care is a prescribed service which is covered under, in part, Medicare Part A and in part Medicare Part B, depending on your circumstances, which we'll get into in more detail in just a few moments. And so recognize you're not necessarily talking about an out-of-pocket cost in the case of prescribed home health care, for which there's an interdisciplinary team that's going to include a nurse, a social worker for psychosocial support, and is going to also include a home health aide for assistance with some of your activities of daily living, which we'll refresh your memory on through this presentation. So when you see the number 4,000 to 8,000, recognize that some of that is going to be covered by your Medicare or by your private care or by a combination of both insurance benefits. If those of you out there have long-term care insurance or short-term care insurance, ultimately, this may be a potential place where that cost is covered as well, but you're looking primarily at your Medicare or your private insurance for that. Sad to say, that is not the case for home aid services. And that's ultimately where you're paying for, again, some minor assistance with your activities of daily living, but it is not prescribed because it is not reimbursable and ultimately is an out-of-pocket cost. And depending how many hours a week, a month that you're looking at, you could be looking somewhere around the $4,000 to $8,000 range. We talked in a previous session on living options about adult day health care. Think of this as the example that we used in previous presentations about, say, the Amazing Place or Care Partners Dementia Day Center. When we're talking about day memory care, we're talking about the opportunity for primarily for respite for the caregivers while there are activities that are supervised as well as meals and other cognitive stimulation throughout the day for those living with Alzheimer's or other forms of dementia. And on average, you can look in Texas, at least in our area, at about $1,600 a month for something like that. Now, again, those numbers are merely ranges, and you'll need to talk directly with service providers. If you have elected to go the private pay route and are medically qualified by a physician for assisted living facility care, this is a licensed facility of anywhere from 4 to could be over 100 beds, depending on the size and scope of the operation. You are looking at, on average, remember, in our previous conversations, we talked about how this could range from, say, $1,600 to $10,000 a month. It really depends on the setting in which you find yourself, the amenities that are offered as part of your baseline cost, and those things that you pay for a la carte on a monthly basis beyond basic care. I specifically put in licensed personal care home as the next category on this slide. For those who have not been with us, let me remind you of my feelings about unlicensed personal care homes, which is caveat emptor, buyer beware. Ultimately, you have yourself an option of working in a landlord-tenant relationship with someone who perhaps you have developed a relationship with in the past, who is saying, come to the place that I am operating. 3 beds or less does not require that you be a licensed facility in the state of Texas. And I will make sure to take good care of you. God willing, that's exactly how the arrangement bears out. But just in case it doesn't, please be aware that your protections in an unlicensed personal care home setting are less than what we are talking about in licensed assisted living facilities, and certainly in licensed nursing facilities where you can expect the most robust set of rights, period. Now, I put in that last category in parentheses the term skilled, because ultimately we do want to recognize that for some people, there is going to be a short-term stay. If they don't end up in, say, an inpatient rehab facility or in a long-term acute care hospital, which is going to be a step down from whatever hospitalization they may have experienced beforehand. If you don't end up in one of those places, odds are you're going to end up on the skilled side of a licensed nursing facility. Now, you will enjoy the same rights as those who live there long term. But keep in mind that should you decide to stay in that facility And you, of course, your Medicare or your private insurance is only going to cover a finite period of time in that facility. It's going to cost you upwards of $7,000. We put an average here of $7,200 plus a month. And whether you are in a position to pay privately each month and then reach the point where both medically and financially you qualify for Medicaid benefits, which will, along with your monthly applied income, cover the cost of that stay minus a very modest personal needs allowance, then which we will look at in a little more detail in this presentation. Ultimately, keep that in mind. Ultimately, if you are changing that over to your primary residence, you are pretty much signing over the bulk of your assets towards the payment of that stay. Unless you are blessed with enormous wealth. If you are, God bless you, and consider staying at home. Before we step into the difference between Medicare and Medicaid, because I know that this is chock full of different information, which may be familiar for some, unfamiliar for others, let me go ahead and just take a quick peek here. So I'm looking at the meeting chat, and I see Joyce has put, we use long-term care insurance for my mother now, 93, blind, has 2 part-time caregivers. I cannot tell you that was a good option. My brother was given reasonable premiums as a federal employee. When he retired, premiums were over $1,250 a month for several years. We will never break even in mom's lifetime. I believe if one uses insurance for in-home long-term care, start as early as possible to justify the costs. Thank you for that, Joyce. And we absolutely are in sync when it comes to this kind of thinking. If you have the ability to go ahead and to buy into long-term care insurance, or for that matter, short-term care insurance, both of which we'll discuss later on in this presentation in general terms, then yes, that's the equivalent of when I was in my 30s. My wife and I, who also was in her 30s, decided that we were going to go for a 30-year term life insurance plan. And the premiums at the time were pretty expensive for us because I was not that far out of seminary. My wife was not that far out of law school after switching career paths. And we were dealing with student loans as well as now an annual premium. I can tell you that 20 plus years into that 30-year plan, it remained fixed. Thankfully, our income did not, and our debt load did not. And therefore, it's one that we pay with a smile because we got it locked in when we went ahead and signed up for it 20 plus years ago. So the same thing in general will apply for long-term care insurance. I'm not so convinced short-term care insurance, depending on what you're looking at, is going to offer you the same lock-in. But again, it depends on the company. And more importantly than anything else, regardless of the reputation of the companies that are providing long and short-term care insurance, they have to remain solvent in order to pay out. Mm-hmm. So keep that in mind as well as you look at companies, especially if they're publicly traded, whether or not these companies are going to be able to actually perform as expected. And if they can't, and you join a class action lawsuit against them, God bless you, but they may just go ahead and declare bankruptcy and you're out your investment. I don't want to scare anybody about this. I do believe that for the right people in the right situation, long-term and short-term care insurance makes sense, but it depends on your ability to buy in early. So Joyce, you're absolutely in sync with where both Peggy and I are thinking about such options. But we also recognize that the vast majority of Americans are one paycheck away from disaster, which is to say, very few of us are prepared to go ahead and to spend and spend and spend when it comes to retirement, let alone the type of care that we may need in those years without the benefit of programs like Medicare and, when necessary, Medicaid. but it's important to understand what they are so that you know what your safety net provides you. And they are safety net plans. So let's talk about it in some detail. Here's the overview of this, or at least the first part. Medicare, as some of you may already know, if you are already a recipient, is a federally funded program primarily for those who have aged into it, starting at age 65 currently or above. In my generation, we'll see if it stays that way or if it goes up to 67 or 70. But for now, it is 65 for Americans, or you qualify by virtue of disability. And ultimately, that's going to be a process of medical evaluation and ultimately a decision that is going to be made about whether or not you qualify for some type of Social Security disability. So it is in combination with two agencies, the Centers for Medicare and Medicaid Services, which make sure that Medicare and Medicaid run the way that then in theory they're supposed to, but also Social Security in terms of understanding what the actual payout is going to be towards your care, in addition to your income, should you be disabled. In other words, the two go hand in hand. Medicaid works in a somewhat similar way. It's primarily state funded with some support from the federal government. And here, states have the right to opt in and they have the right to opt out of post-Affordable Care Act Medicaid expansion, what is sometimes referred to colloquially as Obamacare. Texas is a state that has opted out of Medicaid expansion, and the impact on seniors is noticeable. And I'm going to just leave it at that. Now, as far as Medicare is concerned, your eligibility, if you have paid into the system for at least 10 years, you or your spouse, you are eligible for Medicare. Now, I'm going to assume that you have also gone ahead and done such proper things as pay your taxes on time, not attempted tax evasion or something that's going to go ahead and disqualify you because of IRS penalties. So let's assume that you are not breaking the law and you pay into this system. And for those of you who have ever earned a paycheck, you know exactly how this works. A portion of your check is taken out each month, each pay period, whatever it is your frequency is, to go ahead and to prepay, or if you will, buy into the system for later dispersal of funds in your direction for both Medicare and Social Security, and if you qualify ultimately for Medicaid as well. And with Medicaid eligibility, the primary thing you need to know about for the purposes of our conversation today is that it is limited income and financial resources. I've got a chart later on that gives you a sense as to just how limited we're talking about in terms of what savings you can hold, liquid savings, not tangible assets such as a house or a vehicle, but liquid savings. And then to talk about limits on income. And this is going to differ from state to state, along with a very interesting program called MERP. Ultimately, it is a recovery program that some states have opted into and some states have opted out of when it comes to after you are gone and you have and your estate is being settled. The state may say, well, we invested in your comfort in a nursing facility, and that cost is going to come back to us when you liquidate your assets, such as your home. Now, before you get panicked about this, there are absolutely exceptions to this rule in states where this recovery program exists. You're going to want to talk to someone in the legal profession, whether you have your own estate's planning attorney or whether you want to use the services of such places as Lone Star Legal Aid or the Texas Legal Services Center and so forth. Ultimately, if you can protect your property, they will help you find a way. But I don't want that to be an impediment for you if you find that medically and financially your best option is a bed in a nursing facility. Use your benefits. Take care of yourself. I understand the desire to go ahead and to protect assets and savings for future generations, but your quality of life matters. And we never want you to think less of yourself. I mean, I know that there are personalities, generational cohorts, perhaps in general, that qualify for the no, I will sacrifice so that there's something left behind for the next generation. I salute you, but I urge you to reconsider when it comes to meeting your day-to-day needs when you are in the greatest need for assistance with your activities of daily living. So here are the parts, the famous parts of Medicare coverage as it exists today. We're in the middle of an enrollment period, by the way. So this is something for those of you who are already utilizing Medicare to go ahead and to just keep in mind, if you haven't already been bombarded by literature reminding you that you're in an open enrollment period, and especially when it comes to Part C, how desirable it may be for you to consider moving out of traditional Medicare and into what is called a Medicare Advantage plan. But let's talk about all four parts in general. Part A is your general hospitalization plan. There's no premium for this. There are absolutely deductibles for this, though. And so for those of you who have been hospitalized and Medicare has been your primary form of insurance coverage, go back to the very beginning of our series when we talked about healthcare rights and responsibilities. This may be, depending on what savings you have, a situation of where you are, in fact, under-resourced, or may have found yourself under-resourced when it came not to paying the entire bill, mind you, but paying your deductible. And if that is the case, remember what I said in the very first session. And if you weren't with us in our very first session, go back to the recording and you'll hear me use this phrase. I'll repeat it the same way I repeated it there. Negotiate, negotiate, negotiate. Hospital and healthcare systems would rather see partial payment than none. So keep that in mind. Moving from Part A into Part B. This is your major medical. Major medical is everything that you may need to go ahead and to thrive outside of the hospital. And it's primarily, we're talking about being covered as a result of a prescription for said services. This is why I mentioned, for example, earlier that home health care, depending on the circumstances, could be primarily covered by Medicare Part A if you're finding yourself coming out of the hospital after, God forbid, a fall, a fracture, and you've completed rehabilitation in some type of post-acute facility. And now you're continuing your rehabilitation at home through home health care. That's where the skilled rehab services are going to be paid for primarily, is out of Part A. Whereas the major medical part, whether you came out of the hospital or whether you've always been at home, but you've been to the doctor and it's been determined that you would benefit from home health care services, then you're going to see primarily some of those rehab services, but also what's referred to as DME, durable medical equipment, everything from a cane or a rollator to a specialty bed and even a Hoyer lift to get you safely in and out of that bed if you can't support your own weight transferring yet. Those are the kind of things that are going to be covered under Part B, the major medical plan. Now, when you get to Part C, in fact, let's skip Part C for a second because I want to get to Part D and then we can bring Part C back into this. Part D is your prescriptions. And we're going to talk a little bit about what used to be called and is still referred to colloquially as the donut hole. When it comes to the gap in insurance and the out-of-pocket costs that you as a Medicare recipient may incur under traditional Medicare coverage. We'll get to that in a moment. Now let's go to Part C. Part C is what we now are being bombarded with by Joe Namath and Bill Shatner and all these wonderful spokespeople about Medicare Advantage plans. And remember, they talk about how they come at no cost to you. Well, there ain't no such thing as a free lunch. Well, even then, we may hit you up for your attention. So, your time is worth something as well. So, in general, a Medicaid Advantage plan is something you're going to want to take a serious look at if, in fact, the way that it covers in place of traditional Medicare, Part A, the hospitalization, Part B, the major medical, and Part D, the prescriptions, if it is to your financial advantage to essentially go into what is more or less an HMO. If that is an advantage to you because there are lower costs associated with it overall, as opposed to premium costs, then great, go for it. I will say this, it is our experience, Peggy's and mine, as well as those in the long-term care ombudsman program, area agencies on aging and more, that if you are already living in a long-term care facility, there is customarily, there is no great advantage to Medicare Advantage. So keep that in mind. Traditional Medicare is usually all that you need. And if you, in a nursing facility, financially qualify for Medicaid on top of that, God bless. But once you've reached that stage, there may be exceptions. And I always want to point out that exceptions may apply. But in general, if you are already in a long-term care facility, stick to traditional Medicare. Unless someone has convinced you with some real evidence that there is a true advantage to signing up to a Medicare Advantage plan. Do not accept the word of those walking through those long-term care facilities with smiles and brochures and swag, telling you how this is going to come at no cost to you. The facility doesn't particularly want you to sign up for a Medicare Advantage plan. Because ultimately it's an extra step for them, because what's going to happen is your monthly applied income is going to be charged for that Advantage plan. And normally that would go directly to the facility. Now they're still going to get that amount because it's considered a necessary exemption if you've decided to sign on to an Advantage plan. But they now have to get it from Medicaid, and it involves an extra step from their business office. So it's not to say that that suddenly they're getting less income. It's become harder for them to go ahead and to get it in a timely fashion, which is why they're not fans of it. But that's not the reason why we're saying think carefully. The reason we're saying think carefully, especially in a nursing facility, is that by the time you qualify after a spend down period for Medicaid, Medicaid's going to cover everything and more that an Advantage plan is going to cover otherwise. So again, food for thought, always consult with a professional beyond these walls when it's your time to make such a decision. We're going to break down in brief each of the parts of Medicare. As I mentioned, Part A Medicare is going to go ahead and cover your hospital stay minus a deductible, negotiate. If for some reason your out-of-pocket costs post-deductible are beyond what you can reasonably pay while also maintaining your household. Just please never forget to do that. After you're gone from that hospital, your discharge plan may include institutional skilled care. And you heard me discuss last week how if it is humanly possible to go to a long-term acute care hospital or an inpatient rehabilitation facility, not the skilled side of a nursing facility. This is no knock on the skilled service providers in that nursing facility, who are usually at this stage contracted by that facility to come in and to provide you with physical therapy, occupational therapy, if necessary, speech therapy, and more. They're wonderful. But the staff who's helping you get ready for those appointments, you make sure that you're clean and dressed and fed and ready to put in the work. That is a constant issue nowadays in these nursing facilities. And you will not be treated any differently just because you're there short term. So keep that in mind. It's going to involve a lot of advocacy and a lot of vigilance if you find yourself there, to make sure that you are ready to go when skilled rehab or other skilled services are available for you. Now, I will point out that ultimately Medicare does have a benefit limit of 100 days. I mentioned that here, and we'll look at it again in a moment, because you can see the long-term acute care hospital box on this slide. We're usually talking about long-term care when it comes to antibiotic, to wound care, and so forth. This isn't necessarily for skilled rehab, but you may find yourself hospitalized for long-term infections that require IV antibiotics. God forbid, a really bad wound that needs debridement and regular care. That's where the long-term acute care hospital, the LTAC, really is your primary choice if you can get in. But keep in mind that they do have a lifetime benefit limit. So if you are in need of physical therapy, occupational therapy, and so forth, the IRF, the inpatient rehab facility, is going to be your proper track. It's not that they don't have the staff to also help with wound care and IV antibiotic therapy, but they're going to be seeing your rehab track as the primary reason you're there. Now, this part is important. You're going to have to demonstrate that you're able to withstand 3 hours a day or more of your various therapies. Rest assured, that does not mean that you are suddenly being put on some kind of forced march for 3 hours a day. Mm-hmm. What we're talking about is a cumulative amount of physical, occupational, speech, and other types of therapies. Of course, you're going to get breaks. Of course, they're going to space things out because you reach the point of diminishing returns in any given session. But over the course of a day, you're going to need to be able to go ahead and to handle a cumulative 3 hours of various therapies. If you can demonstrate that, an inpatient rehab facility is wonderful. One of the deficits that you may find because of what I mentioned about staffing in nursing facilities is that you may not get that full 3 hour benefit a day if you are stuck in bed or you haven't been dressed or fed and ready to go yet. So, things to keep in mind as you consider your discharge planning. God forbid you ever need it. Now let's continue to talk about Part A by talking about other types of care, different stages of life care, if you will. The one that we've already covered is in the lower left-hand corner, and that's the home health care piece. It's prescribed therapy. Again, whether it's Part A as another step out of the hospital, either directly to home or via the inpatient rehab facility, the LTAC, the skilled side of a nursing facility, if you must. And it is ultimately going to go ahead and continue your recovery process through there. Now, if you find yourself in the situation where you've been examined, but not necessarily hospitalized, and your physician, whether it's your primary or specialist, say you could benefit from home health care, from skilled services. And that will usually include some type of physical, occupational, and/or speech therapy, in addition to the assistance with some activities of daily living. Then it's going to be Part B, the major medical part, that's going to cover that, as opposed to Part A, your general hospitalization. That word that's in that box is critical: homebound. If you can't go to outpatient therapy, that's when home health care is paid for. If you can go to outpatient therapy, then you are most likely, for assistance with your ADLs, looking at an out-of-pocket option if you don't have enough friends, family, faith community support, what have you, to go ahead and to help with your activities of daily living, let alone driving to and from. Now, there may be options available to you if you are a person of means, and that's wonderful. But keep in mind that being homebound means that ultimately you are not physically prepared to work at the intensity level of an outpatient therapy level. Now, in terms of whether or not you can physically drive yourself there or not, yeah, it's a factor. But the counterpart to that is there are transportation services that are available, whether you're talking about in our community signing up temporarily or permanently for MetroLift, or whether you're talking about going ahead and simply making really good friends with your Uber or Lyft driver, let alone going ahead and talking with friends and family about transportation. One thing about transportation, though, it's not just about destination to destination. If your mobility has been challenged, which is why you are dealing with why you are prescribed some type of therapy, it's about getting you literally from your bed to set up with your walker or rollator, to into the vehicle, to exiting the vehicle, to the door, and into the outpatient therapy place. So keep that in mind when you're talking about transportation as well. There is a category of transportation that traditionally handles that. It is referred to as NEMT, non-emergency medical transportation. It's a little more expensive, I'm sorry to say, than a MetroLift, than an Uber or a Lyft driver, but it is designed with that out of bed and into your therapy situation destination in mind. Now let's talk about the other major part of Part A. If you find yourself in a situation where you would benefit from palliative care, symptom management. Now, this may not always be because of the category next to it, which is hospice care. Think of comfort care as an umbrella under which you have certain categories, such as symptom management, palliative care. And if you have a terminal diagnosis for which the prognosis is 6 months or less, that doesn't mean you're going to die in 6 months, but it means that the traditional trajectory of your disease is that it is expected that an average person will, in fact, pass within 6 months. Ultimately, you will qualify for, and Medicare will cover, everything involved with hospice care. Now, you are not allowed to double dip. In other words, if you have reached the point where you are in hospice, then you need to actually unenroll from hospice if you pursue aggressive care measures. And this isn't necessarily related to the terminal disease that qualified you for hospice in the first place. This is if you have cancer, but while you're in hospice care, God forbid you take a fall and you need to go to the emergency room. Well, you're going to need to unenroll from hospice in order to have your Medicare cover the emergency room stay. And after you're out of the hospital, because hopefully it was just a scare, you're going to re-enroll in hospice. I know. I worked in hospice. I know. But ultimately, the way Medicare is written is that you cannot double dip. So aggressive care and hospice care cannot both be paid for simultaneously. So that's why you got to go ahead and jump ship temporarily if you find an emergent need that's going to take you to a hospital. And then after that emergent need is dealt with, to return to hospice care and continue to focus in on that level of palliative care for you who qualify for hospice because of a terminal diagnosis and a 6-month or less prognosis. I will emphasize again, if you have a 6-month or less prognosis, keep in mind that hospice care can improve the quality of your life, which in turn can actually improve the quantity of your life. When I worked in hospice care as a chaplain, it was not unusual to see people constantly recertified for hospice eligibility, remain in hospice care, and remain on service for over a year and a half, 2 years. Yes, they are dying, but because they're not being bombarded by aggressive treatment and they are receiving incredible home care, and this is above and beyond what hospice can provide because it is not a 24-hour care service. It is an emergency service when needed, but ultimately scheduled like home health is scheduled during the week. You ultimately can see a person's quality and quantity of life extend farther than you might imagine. But again, keep in mind, you always can send someone or send yourself to the hospital if you have an aggressive need. It just means you need to unenroll from hospice during that period. So, Part A Medicare. This is the fun part about qualification. The 3 midnight rule. This is canon, legal canon, as opposed to biblical. 3 consecutive midnights in any level of admission of admit care. If you are there on observation, you are not admitted. Your inpatient status is not that of admitted patient. And ultimately, you are not going to go ahead and qualify for Medicare coverage for, say, a skilled part of a nursing facility stay to continue your rehabilitation. Now, the good news is that usually you are admitted if you have a fracture, because it's going to involve some type of setting of that, either surgical or not. And so ultimately, the 3 midnight rule should be pretty easy to take care of. 3 consecutive midnights in the ICU is what's going to qualify you for a long-term acute care hospital in LTAC. Now, keep in mind that an LTAC is not just there to handle helping you, say, rehab from a fracture. They're primarily there to go ahead and help with wound debridement and care. They're primarily there to help with infection control and making sure your IV antibiotic therapy is effective. Those are going to land you in the ICU in order to protect you, because not only is the ratio of care better in the ICU, but the ability for you to avoid general infections on the floor is going to be higher. That's not to say you can't catch an infection in the ICU, but you're in a different type of setting in an ICU where ultimately infection control procedures, I think, are more rigorous. Now, the observation versus admit status isn't going to apply to inpatient rehab facilities. So that is the one exception in there where ultimately you could argue to your advantage if you come in with a fracture, but it's a hairline fracture. It's going to involve rehab, but you don't end up staying 3 midnights and they want to discharge you to home. That's when you work with your doctor and say, yeah, hairline is great. I can't put any weight on this leg. And so the only place for me to get my activities of daily living taken care of is going to be in a post-acute facility, not at home. And they say, well, you don't qualify for a nursing facility stay where skilled services apply, to which you say, hallelujah. I qualify for an inpatient rehab facility stay because it's not a part of the 3 midnight rule. So in the end, What I'm trying to say is never accept at face value the discharge plan that is put in front of you. Always reality check it versus your actual needs. And if necessary, go back to the social worker, the case manager, whoever is involved with your care, and say, this is going to work or it's not going to work. We need a different option. They can't unsafely discharge you. Let me repeat that. Hospitals are not allowed to discharge you without a safety plan in place. They may put a lot of pressure on you to go. And I recognize the psychological pressure is real. At the same time, that's when you ask for a patient advocate, for a chaplain, for an ethics consult, whatever it takes to get other pairs of eyes and ears in your room with that discharge team, which is primarily doctor, social worker, or case manager, or some combination of the above, and work on a plan that works best for you. The other example of that isn't necessarily an example of type of facility, because let's assume that you meet the criteria to go to any one of these three facilities. It's also about location. Now, sometimes you're going to be in communities where there's only one or two locations that can meet your specific needs post-discharge from the hospital, and that's just life. Most of the time, and especially in a city as large with as much depth of healthcare options as Houston provides, you're going to be able to say, let's see what we can do to find a bed that's closer to those members of my safety net, family, friends, community, that are going to be able to come in regularly and advocate for me as I go through my recovery. I am obviously having a bad day, week, or month, and I'm not at my best. So keep that in mind as well. Couple things that are listed in here as well is that ultimately you've got 30 days if you qualify to go ahead and to admit into that inpatient rehab facility or the skilled part of that nursing facility stay after discharge from the hospital. If you said, nah, let me try from home first, make sure it's still written in your chart that you qualify, because if you get home and it's a disaster, and no matter how good home health care is, you just need more care than they're capable of providing because they're not there 24/7. Go. You have 30 days. It's okay. Psychologically, I understand the desire to be home after a traumatic event, but you have the option of taking them up on their discharge plan if what you have decided in terms of just a direct return to home isn't working for you. Keep one other thing in mind as well. There's a 60-day restart period from incident to incident in terms of your Medicare up to 100-day eligibility for post-acute care. Yeah. For those of you who can't see, there's a couple of looks in the room of, you've got to be kidding me. And I wish I was.
Is that like if you break a leg and then you break an arm?
If you break a leg and everything that is Medicare related from your hospitalization to your post-hospitalization stay, is underway, and along the way, you find yourself in an inpatient rehab facility, you twist and turn the wrong way, you fall and you break that arm, that is a separate incident, because don't worry about the 60-day break there. But we're talking about for the same condition, okay? Because let's face it, life is random. The ambulance transporting you from the hospital to the inpatient rehab facility could be T-boned. And that's a separate incident. That's a separate incident. A fall in an inpatient rehab facility where you break something else, separate incident. What we're talking about in terms of the break, it is ultimately for the same medical issue. So that's where your lifetime benefit, your benefit, that up to 100 days of benefit on that incident can be reset after it is not an issue for 60 days. Okay. In other words, not an issue doesn't mean you're 100%. Not an issue means you're no longer requiring Medicare paid services in order to complete your recovery. If that same issue comes up again within a 60-day window, your whatever coverage you have left, if any, is going to apply. If it's after that 60-day window, it restarts the eligibility clock of your 100-day max. But if you have a separate incident, no, that's a separate incident and it's under separate coverage. I am going to leave charts for the sake of time for you to look at afterwards, as far as the various deductibles, co-insurances, and such. Suffice to say that you may want to talk with whoever you're paying for post-acute care services, just like you would negotiate with a hospital for your deductible, just in case you're finding that the daily deductible rate is, for example, or the deductible for the entire stay is, I don't know, going to go ahead and interfere with your mortgage note or your rental note. In other words, if there's a hardship exemption, that's the general term that's used, even if you are not a current Medicaid recipient, talk to the experts in the system you're in. It's possible for Medicaid to still jump in and provide a hardship exemption. You will have to demonstrate financial need. But like I said, this is part of the negotiation process to go ahead and to cover whatever you can pay out of pocket and at least provide partial payment. Or if it's a copay issue and they say, you got to pay the copay or we're kicking you out. Besides the fact that a long-term care ombudsman, if you're in a nursing facility, can help you defend against that involuntary discharge, there are also hardship exemptions that may be in place. A smart business manager, an experienced business manager in a nursing facility where skilled services are provided is going to know that. One who is less experienced may not and needs an education. That's when you call the long-term care ombudsman for support. Part B, the major medical piece. We're just going to talk about this in broad brushstrokes because ultimately, for those of you who are on Medicare, you are already using this on a regular basis, whether you realize it or not. Medically necessary services and supplies isn't just for an acute condition. It can be for chronic conditions as well. Say you're a diabetic. Preventative services, labs, outpatient visits, diagnostics, outpatient medications. And if you have a medical need and the unmistakable sign that there is a medical need for which Part B Medicare, the major medical side, is going to cover it, is going to be the prescription. That is the gold standard. If you have a prescription for durable medical equipment, for medically necessary services and supplies, and everything else that's in this overlapping of circles. I know I chose a strange graphic, but ultimately, what I want you to recognize in all of this is that ultimately Medicare is there to cover it if it is prescribed. And again, you'll have a chance to look at the slide in greater detail. Medicare covered home health services. We've covered a great deal of this in terms of supplies, social services, the various therapies, the home health aid, the nursing care. Ultimately, a couple of things I want you to be aware of on this slide. As I said before, you've got to be homebound in order for home health services to go ahead and to qualify as a covered benefit for you. Now, this is the important part. There is no limit so long as you continue to meet the qualifying criteria for skilled therapy. Companies are going to want to go ahead and say that there is, because as more time passes, their reimbursement rate decreases. Medicare has a sliding scale of reimbursement rate for them for their services. So if they start going ahead and saying to you, well, we've got to discharge you from services, even though your physician says that you still medically qualify, get that physician on the phone, get the area agency on aging on the phone, and get them to advocate for you, as well as to you, the best of your ability, advocate for yourself, because they're not supposed to do that. But because we live in an age in which for-profit is the primary vehicle for delivering home health services, hospice services, and so forth, you are sometimes going to need to hit them with a 2x4 and remind them of your rights. And ultimately, when they are given a gentle reminder, and also reminded that they could face sanctions and a fine if they go ahead and they continue to try and play fast and loose with this regulation, they will go ahead and they will see the light. Having said that, the law authorizes up to 28 to 35 hours a week of combined discipline services. That's everybody. That's the home health aide. That's the nursing services. That's the social services. So keep in mind, you're going to need to cover the gaps in between. If you have a need for assistance with your activities of daily living when they are not in place, home health services, this is where home aides or relying upon community, family, friends is going to prove essential. So we want you to be forewarned that that like hospice, home health services is not a 24/7 operation. Again, another chart for you, just so you can go ahead and see what the monthly premiums are under traditional Medicare for the Part B services. Remember, you're in an open enrollment period. There are also qualifying event periods, but I don't want to confuse matters. So let's just focus in on ultimately the general period of time for these things. This is going to cost you, but again, we're looking at a sliding scale based on your declared individual or joint income.
Income or assets?
Income. Yeah, because if we're looking from an asset perspective, then everything gets skewed.
Income would be
income
based on your income tax filing.
Income is going to be your AGI, your adjusted gross income. And primarily, it's going to be, for most folks, a combination of your monthly Social Security disbursement and any kind of pension that you have earned, or if you have purchased some type of annuity, or if you have mandatory, based on age, mandatory disbursements of anything in various types of IRAs, individual retirement accounts. So whatever is going to be part of that adjusted adjusted gross income is going to be what counts in your individual or joint filing. So it is going to pretty much follow your IRS your filing as far as that goes. Now, if you don't normally, because of income, have to file for IRS, you're still going to want to go ahead and make sure that you have an official tally of your income for verification of your premium amounts. You don't want to be audited. Medicare Part C. What I will say about this is that if you are in the community, it might be nice to have a Part C plan that covers Part A, Part B, and Part D. It might be nice to go ahead and to have that plan, depending on what you choose, include dental, vision. I know hearing aids are now over the counter, but again, it depends on what it is that is going to work best for you, and that may still be prescribed. Just like reading glasses have been over the counter for years, but you may need something that's specifically prescribed for you. And ultimately, in-home supports and modifications. The goal of a Medicare Advantage plan is to keep you at home, if possible. If you are at the point where a long-term care facility stay is inevitable, then, as I mentioned before, this isn't necessarily the best plan for you. But you're going to want to reality check that. Don't just take my word as gospel, because individual situations are always going to be more accurate than trends. Now, what I will say is that there are currently over 60 different plans in Harris County alone, with different premiums, deductibles, maximum costs, and so forth. But the flip side of this, and you'll notice I put in italics, that there are also limits on covered doctors and hospitals. Falkenberg refers to Houston Chronicle reporter Lisa Falkenberg, who went through her own struggle with family over purchasing Medicare Advantage plans and then arranging to get the full use out of them for loved ones. Those links are in the resource part of the slides you will receive. So you can look at that and look at lived experience as this process continues to evolve. I won't say that this is Wild West. It is heavily regulated, but with such varieties of plans that are out there, you really do need to be careful in terms of making sure that you pick one that is not going to hamstring you when you need to maintain or start a relationship with a particular physician, a particular specialist, a particular hospital. Those are things you're going to want to do your research on first, ideally. I mentioned the donut hole much earlier in our presentation, and I do want to go ahead and point out that the coverage gap actually closed for all drugs in 2020, which doesn't mean they're free, I'm sorry to say. But what it does mean is that when you go ahead and enter that coverage gap, and inevitably you're going to go ahead and hit a period of time where you're going to max out. Usually most people on traditional Medicare do, where you're going to max out on the zero deductible part of the cost of your regular prescription or as needed prescription medication. There's now a cap, and the cap is 25% of the cost of your drugs. Do not forget, you can also take advantage of programs that are out there like GoodRx and other such things that are advertised that may go ahead and help bring the price down. Also, do not forget that those may not apply to name brand medications. They might, but you need to reality check whether they will or whether they only apply to generics. And also, you need to discuss with your prescribing physician whether or not a generic is going to do the job for you as well as a name brand. Usually, the answer is yes, but it would be the height of hubris for me to say that that is the way it works for every individual. So please, please, please talk to your physician. And if you fall into the category of someone for whom the name brand is a must, then follow their advice, please. Or get a second opinion and then follow their advice. But whatever is best for you. My advice is strictly general. Medicaid itself. What's important to remember about this is that ultimately we're talking about something that is state regulated and is going to apply primarily to low-income adults, children, the elderly, and disabled. And for the purposes of time, I want to go ahead and I want you to see ultimately there is traditional Medicaid, which provides limited coverage for home health services, durable medical equipment, infusion care, and hospice. And then there is HMO Medicaid. Just like a Medicare Advantage plan is an HMO style of Medicare, there are combination plans that are out there. Star Plus is the one that's most commonly thought of here in the state of Texas, where you have a combination Medicare and Medicaid plan. And if it is a Medicare Advantage plan, which is HMO style, it's going to be a Medicaid plan usually that's HMO style as well. All that really means is that you require pre-authorization, just like in an HMO, by any other name, your primary care physician has to make a referral to a specialist in order for you to see the specialist. It's an extra step, but again, it may be worth your while to go ahead and to take that route. Now, if you are looking at a long-term care stay, then ultimately you are going to be going ahead and using Medicaid to cover that stay once you get your spend down period in that long-term care facility, that nursing facility, down below your savings and income thresholds, which we're about to get to. Okay. This is the part that is the good news, bad news. So, good news. Irrevocable funeral trusts, funeral plans, a home, a car. These are going to be excluded from Medicaid eligibility consideration. That's about it for the good news. The bad news. Texas has poor reimbursement rates, which make doctors less likely to accept Medicaid. So your pool of physicians shrinks as your income lowers and your eligibility for Medicaid becomes viable. There is a 5-year look back period. So if you established, say, we talked about the legal considerations category of aging with grace. If you established a trust, irrevocable or revocable living trust for the family, and more than 5 years before you need Medicaid, great, good for you. But if it's within a 5-year look back period, there is going to be an out-of-pocket cost to you until Medicaid eligibility commences. The medical and financial qualification. These income caps are what they are. And I'll leave it at that. An individual income cap of $25-23 a month. A financial asset limit. This is liquid assets, savings primarily, of $2,000 each month. You go above these, you jeopardize your Medicaid eligibility. When there are stimulus packages, as we received during the early stages of the pandemic period, for a 12-month period of time, these don't count towards that financial asset limit, but you got to spend it within that 12-month period. Otherwise, it can put you over and compromise your eligibility. Now, you can see that there's also an important piece that's in there for those who are married, watching this recording in the room, who are looking at having one spouse apply for Medicaid. You're still looking ultimately at the same numbers we're talking about for the applicant, but take a look at the non-applicant. They are allowed to retain a maximum of $137,500 under what is called the spousal impoverishment rule. This is to make sure that if one spouse reaches the point where they say need to live in a nursing facility, and that nursing facility is going to go ahead and take them in and put them in a Medicaid bed. Remember, what's going to pay for that bed is going to be their monthly applied income minus a personal needs allowance, which is $60, $80 a month on average. Bupkis. And they're going to use their Medicaid benefit to cover that stay. Now, they can't come for more money after the spouse, because ultimately spousal impoverishment laws allow that spouse to do whatever they need to do in order to stay in their home. So ultimately, that applied income is going to get cut just a little bit, because some of that's going to be applied towards the spouse's monthly income. Medicaid's going to make up for that, for the facility as far as their payment. And your ability to keep up to that $137,500 in assets is going to be protected. Is that a ton of money in terms of overall savings? That depends on you. Objectively, not really. But for you, it could be the difference, the spouse who is not in a nursing facility, between maintaining your home and not being able to maintain your home. And that's a big deal. That's also a big deal when it comes to the last piece that's in here, which is called MERP. I mentioned earlier, The Medicaid Estate Recovery Program, if your state participates in this, they can come after you to recoup what they paid out for your or your loved one's nursing facility stay. It's usually your loved ones, because very few people will graduate out of nursing facility care unless they are on what is called a money follows the person program, which is a Medicaid funded program where there is a medical determination that they can receive nursing facility type of care in a home environment. That is a completely different topic for another day. Suffice to say that the majority of the time you are looking at survivors of a loved one who has died, who are facing the possibility of dealing with the Medicaid estate recovery program with MERP. If you've got spousal impoverishment in place, usually you've got an exemption already in place. That's why I don't want it to scare anybody who is watching this live or listening to the recording, because speaking with an attorney, speaking with a legal aid service, it is pretty straightforward getting yourself to a place where you can protect against having MERP affect you adversely. But I do want you to be aware that you're in a state that does that can apply it. Some states have just said, no, we're not going to do that. Texas is not one of those states, I'm sorry to say. Now, for the sake of time, I'm going to go ahead and point out the last few slides that are in this deck. Looking at the long-term care criteria, suffice to say, we're talking about things that you cannot necessarily take care of routinely at home. And that ultimately, as a result of either routine care for things that you cannot handle at home, wound care, feeding tubes, that's what a PEG tube is, dementia or psychiatric needs, nurse supervision, cognitive visual deficits that indicate that you can't be safe and take care of yourself at home. And most importantly, just like anything else that we've talked about, admission to a long-term care facility is based on medical eligibility, which will require a physician's order. So ultimately, that's the medical eligibility piece, not just the financial piece when it comes to Medicaid, as well as just your ability to enter a facility, let alone have it paid for through your monthly applied income and a Medicaid benefit. As far as your financial options are concerned, this is not going to be news to most of you who are watching. Your savings are going to be spent down. They may be spent down at a slightly less frenetic pace if you have paid into a long-term care insurance plan. There is such a thing as short-term, and there is also such a thing as hybrid life and long-term care. I'm going to let you read the slides on those separately for the purposes of time. Suffice to say, caveat emptor, buyer beware. You want to make sure that the company providing these is solvent, that the insurance coverage is actually for a future service you may avail yourself of, and that it has limits that you can live with. For example, long-term care insurance, as long as you pay the premiums, it's going to go ahead and provide a certain amount per day amount, which is going to cover the majority of, if not all of, your long-term care stay. A short-term care insurance plan may be a little bit less expensive, but it may not necessarily qualify in terms of providing payment to a long-term care facility. It may absolutely qualify to go ahead and help cover copays for short-term stays in the skilled side of a nursing facility, an inpatient rehab facility, a long-term acute care hospital. So keep those in mind. Hybrid life and long-term care is another way of saying whole life insurance. It's just another vehicle out there. The primary goal of it is to go ahead and to develop enough capital that you build into it over the years to go ahead and to essentially have a savings plan specifically with long-term care insurance in mind. Couple things. It may not necessarily be tied to inflation. And we know that can be a very big deal. The other piece, and this is the good side of it, is if you don't use it, it can be bequeathed to your heirs. Because essentially, if you don't use it, what you have is a whole life insurance plan. Unlike term life insurance plans, which some of you may already be aware, they time out and there's no benefit unless you die. And if you die in that term, then the specified benefit, so long as there isn't an adverse event that disqualifies, is going to be paid out. When it comes to whole life insurance, that's your money. It's your money from the start. That's the money from your finish, whether you use it or not. You can absolutely dry out your whole life insurance plan, whether it's a hybrid life and long-term care or a traditional whole life insurance plan if you need that cash. The same way you can empty out an IRA if you need that cash right away. There may be penalties, but ultimately that money is yours. Your home may also be yours in total or in majority. In other words, you may not owe any money on your home other than annual taxes and school and maintenance and other costs associated with home ownership, in which case a reverse mortgage, for which there should be an absolute robust process of making sure that you are going through a reputable company, because what we're basically talking about here is a line of equity credit. And like any line of equity credit, after you die, should your home be sold, the bank gets paid first. Same thing in terms of the reverse mortgage holder. It could be a major bank. It could be a financial company that specifies its focus on reverse mortgages. What you want is to make sure that these folks aren't under investigation for deceptive practices and that you ultimately pass a screening. You will go through a screening to go ahead and indicate that you fully understand the implications of taking a home that you own outright, usually, and that you are deliberately turning into a source of revenue that you may take full advantage of, or that you may simply leave open as a line of credit and never take advantage of. But you need to be aware, ultimately, that the bank is going to be paid whatever it's owed, whether it's the minimum balance just to keep that reverse mortgage alive, or whether it's the value of the house if you've tapped it out. Keep that in mind as you consider anything, whether it's a reverse mortgage or simply taking out an equity account on your home. Annuities, like any other form of savings, ultimately, the difference between an annuity and, say, the bulk amount of principal in a Roth IRA or a traditional IRA is that you're not touching the principal in an annuity. There are some annuities you're going to want to talk to a financial advisor that ultimately will be shielded from determining eligibility for various federal and or state benefits. I don't have the time to get into which ones are shielded and why, but I will absolutely recommend that you go ahead and you talk to a financial counselor about getting that squared away so that you're aware of what assets of yours are protected in a similar way that, say, your home or your car or any other type of tangible assets are protected when it comes to eligibility for a particular benefit like Medicaid. So I'm going to go ahead and skip ahead to the resource page, because everything else that I've just riffed on for you is listed in the slides that you're going to get a copy of. And I want to be aware, I am aware of the fact that I am well over time as far as things go. Ultimately, I want you to see the resource pages. Again, you're going to get these along with the rest of the slides. Some of this I've already made mention of, such as the Area Agency on Aging, the Long-Term Care Ombudsman Program. I made reference to the fact that there are 60 plus plans, Medicare Advantage plans in Harris County. Well, here's a list under MedicareHelp.org as to what those current plans are. But you're also going to see CMS and their website, the Center for Medicare and Medicaid Services, Veterans Affairs, Geriatric and Extended Care. We did not talk today, for example, about veterans aid and attendance. And other such survivor benefits that the widow or widowers of deceased veterans may benefit from, and that, like certain types of annuities, are going to be exempt in terms of your Medicaid qualification. So you're going to want to talk, especially if you're a military family, about what benefits are out there, aid and attendance and otherwise, to go ahead and to help with short-term or long-term healthcare needs. And the last piece in here under the reference slides is going to include a whole bunch of articles from CMS primarily, but also from MedicareAdvocacy.org, different states that, again, not everything may absolutely apply, but they have done a wonderful job going ahead and explaining such things as long-term care rates and history guides. California's Department of Insurance happens to do that really well. But again, you're going to need to adjust those numbers for Texas numbers as you get closer to determining if a long-term care facility fit is right for you. And remember Lisa Falkenberg, who I mentioned earlier. Couple of articles that are in here that are available through the Houston Chronicle website. And if you're having any difficulty getting those, odds are we've got them in our files as well. You can just, and on the last page, you'll have our contact information for emailing us. But we want you to be aware of not only one reporter's family's story about how they figured out how to properly deal with and right-size the insurance plan that they needed in order to cover short-term and long-term needs. But beyond that, Genworth has some long-term care cost comparisons. I mentioned the retirement healthcare cost data report at the very beginning of this presentation, and Health Use Services site is there for that. And ultimately, in the state of Texas, it is the long-term care division of the Texas Health and Human Services Commission that you will be speaking to when it comes to Medicaid eligibility. And also, they are a good resource in terms of helping you decide what Medicare plan, traditional or otherwise, is going to be right for you. Again, as you consider choices during open enrollment periods, or if you have qualifying events that allow you to make changes. If you have questions, and I would be shocked if you don't have some questions, I urge you to contact either Peggy or me. Either of us can help you further in terms of understanding the content of today's presentation. But beyond that, to go ahead and to make sure that you are pointed in the right direction, whether it is legal services, whether it is aging services, whether it is long-term care regulation and oversight services, or some combination of all of the above. You do not have to memorize all of this and go at it alone. Mm-hmm. We are happy to reinforce anything that is shared in here and continue to point you in the best direction we know how. With that, I am going to thank everybody who went ahead and joined us, and I am going to say wish all of you a very good week, say a fond farewell. This is the end of our fall Aging with Grace series, and look for us again in the spring. Have a good week, everybody, and you take care.